But I'd like to start with Lance McCracken, who is a professor of behavioral medicine at King's College in London. So we welcome Lance.
Thanks, Mark. Okay, thanks to the organizers for inviting me. I'm thrilled to be in New York. I wish I had more time to look around, but it's been a great meeting. So I'm a clinical psychologist and an academic. Half the week I work in a tertiary care pain service, an interdisciplinary one. So today I'll tell you about a little bit of, I'm not a neuroscience person. I have snuck in a little neuroscience, though, against my better judgment. So you'll see a little bit of strange neuroscience stuff in here. But it's going to be a lot of psychology. Am I advancing? I am not. Can I advance my slides from here? All right. It's going to be a little bit boring if you have to look at this one the whole time. So I have a general theme for today, and it's really about, thank you. The general theme today is about, it's sort of in the background here, I'm talking about psychological treatment methods or cognitive behavioral treatment methods and how good they are, what's the evidence for them, and whether there's some way to improve them. And I'm certainly going to try to integrate some of the topics or themes from this meeting, which is early life adversity, and as I said, a little bit about neuroscience. But something I'm always interested in is how can we make the cognitive behavioral treatments that we do more effective? They all already work okay, but they could work better. And so I would say that if we have a very good model of CBT delivery, a very good model of human behavior, all of the things that we've talked about today from a neuroscience perspective and in looking at early life experience, that our models should be able to incorporate all of this stuff. And this should be included in there. And so that's something I'll try to make some sense of that. But as a psychologist, I'm going to try to present a psychological model and not a brain model. I have a specific model in mind, as you might imagine. It's called the psychological flexibility model. And there's also specific treatment approaches that come from this model. The prototype contextual cognitive behavioral model would be what's called acceptance and commitment therapy. So I'll talk a little bit about that too. So something to understand first is this sort of concept of how some of us in psychology look at human behavior. We don't look at human behavior as just what human behavior as caused by the brain or as caused by the mind or as a result of thoughts and feelings, not solely, but we have what's called a contextual model. Now this word contextual is a little bit complicated or a little bit subtle depending on how you look at it. Contextual sounds just like situation, but in a way it is that and it is more than that. And when we say context, we really mean the situation, but the situation considered functionally, and that is with regard to or with respect to our history. And our history includes a lot of elements. It includes genetic, epigenetic, cultural, direct conditioning, and other verbally based learning history. So there's a lot of history here. A lot of it is learning. That's the stuff that psychologists are interested in. Some of it is genetics, and so forth. So situations coordinate our behavior by virtue of our history, all these historical issues I just mentioned. So this is what it means to talk about context. It means two dimensions. Situation considered functionally or situation considered historically. So in a nutshell, our behavior doesn't just come from our thoughts and feelings and beliefs or our brain or our mind. We think of it, we model it in terms of coordination by contextually based influences. A little bit complicated, but it is the basis for how we sort of do this. All right, so here's where I try to sneak in a little bit on sort of early life experience and how might adversity fit into some of the things that I usually talk about. So here's just a few basic notions, like how I would look at how does early life experience or early life adversity fit into the kind of behavior patterns that we're interested in pain management. If we take a sort of a somewhat of a behavioral, a developmental point of view on behavior, we would see behavior as emerging from response variability, selection by consequences, and retention. This is also the kind of stuff that we talk about when we talk about operant conditioning, conventionally speaking, for example. These development processes of behavior patterns are also we have verbal or cognitive influences on behavior as well. So these cognitive influences can initiate patterns of behavior, they can elaborate them or maintain them. So you get conventional operant conditioning plus verbal cognitive influence for us humans. If you're not a human, you don't have this verbal cognitive stuff. We do, so we have to take it into account. So these are the historical sort of drivers on our behavior. The trouble with threat or early life adversity is how it sets up these behavior patterns. And this is probably what it does. Threat and avoidance patterns that emerge from early exposure to threatening and potentially distressing circumstances probably undermine some of these learning processes. They probably undermine response variability. If you face something very, very difficult, it narrows the range of things that you will do. The thing that you'll do the most strongly is get out of there. So avoidance is a very narrow pattern of behavior. You also get therefore decreased selection by consequences. If we start avoiding things, we don't run into new things, our behavior doesn't go variable very well. And so you get this kind of decreased contextual sensitivity as well. Again, that's a byproduct of avoidance. It's also a byproduct of the kinds of beliefs we then harbor once we're exposed to threatening situations. The world is a threatening place. I need to look out for myself. I need to protect myself. I mustn't ever get hurt again. If it's painful, I mustn't feel it. There's something wrong with me. I'm always going to be a victim. All of these things are the kinds of verbal learning that can be acquired during early life exposure to adversity. And they have a kind of they create a kind of a contextual insensitivity because, again, they feed avoidance patterns of behavior. All right, so that's my sort of my attempt to incorporate. So how can we see that, that this sort of a basic behavioral model of human performance and well-being can probably sort of include early life experiences. So we have a model. The model is called a psychological flexibility model. We heard one of these definitions earlier that was very precise but impossible to say and almost impossible to understand. And here's another one. So suffice it to say, without me reading this impossible statement, that there's two sets of separate influences on our behavior. Some of them are direct contingency-based influences, direct experience. Our behavior is coordinated directly by the experiences we run into and what happens when we run into them. All right? The other thing that's going on is verbal. We can learn from instruction. We can learn from instructions we make up by ourselves. So our behavior can be coordinated by this verbal cognitive stuff or from direct contact with how the world is arranged. And these things interact with each other. The verbal stuff has a way of insulating us to the effects of the direct experience stuff. And that's what we call insensitivity. So stuck in our mind with certain beliefs about ourselves and the world and what have you, our behavior isn't free to make contact with learning influences in the environment. It can't be shaped, guided, or changed from those experiences. It's kind of it's sometimes called contingency insensitivity, or what we'd call context insensitivity, the root of what we call psychological inflexibility. And that's basically the just inability to pursue our goals successfully in a context that is mixed with verbal and nonverbal influence. Because it's a bit of a mouthful, I tried to say in a different way. in a pain context, you would say that psychological flexibility is the ability to meet pain and discomfort without fighting it, sort of a loose way to say it, of course, to be aware and focus directly on situations one is in as they appear, as they are arranged, not as we think they are arranged, and to take goal-directed action that's effective. So if you want to think about psychological flexibility, that's sort of the essence of it in a sense. So there's a model that, if you're interested in ACT at all, you've seen this model a lot. It's a hexagon. It sort of looks very impressive. It's a shape with all kinds of lines. And you get all these different facets in here. It would take us too long today, I'm afraid, to go through what all these facets mean. Some of them are unusual terms like cognitive diffusion. But you can think about it as three sets of processes that are elements of this model of psychological flexibility, and they're essentially avoidance reduction processes, awareness and attention related processes, and engagement and motivation related processes in a nutshell. That's what we're talking about. So for some years now, we've been practicing our being fluent on this model and promoting it as a way to give us a good set of guides for developing better treatments. And so here's a recent article that summarizes it in a better way than I will be able to do today, I'm afraid, if you're interested. A paper I did with Stephen Morley in the Journal of Pain. So by now, we have quite a few outcome studies that come from this approach to chronic pain. That should be 21 and not 20. It is about 13 RCTs now. They're not all high quality, but the one thing we do have by now, going back to 2004, over those 12 years, we have about 21 outcome studies, and more than half of those are RCTs. In 2016, we've seen the appearance of two systematic reviews and meta-analyses. Here's one. It's by Martien Viehoff and colleagues from Enschede in the Netherlands. Some years ago, they did another one of these systematic reviews on acceptance and mindfulness-based treatments for chronic pain. And here's their update, essentially, is what this is. What they had here is, understand, it's not just ACT trials, it is mindfulness-based treatment trials and acceptance and commitment therapy trials. The ACT trials included nine studies. So you see they had not a huge number of patients, but not too bad, 25 RCTs, around 1,300 patients. And just to get to the meat of what they found in their meta-analyses, they found small effects for pain, depression, and disability, medium effects for anxiety and pain interference. These were all immediate post-treatment effects. At follow-up, and these aren't very long follow-ups, mind you, but for 2 to 6 months after the completion of treatment, they still have some small effects, and these small effects are for pain and disability, and some medium effects for depression and anxiety, and they have a large effect for pain interference in comparison to comparison conditions, obviously. The neat part in this data, something that we see with some regularity, is that the effect sizes for many of the variables tended to be larger at follow-up than at post-treatment. So post-treatment, the effects are pretty good, but they unlike what we often assume, and that is your best treatment effect will be on your last day of treatment and it's downhill after that, the effects here tend to show a pattern of integration or perhaps further improvement in some of the processes with some practice over time. And with exception of pain here, as it says, all of the effects are larger at follow-up, at least marginally. Another even more recent systematic review is this one by Hughes, by a group mostly from Leeds. And this one was just ACT trials and no mindfulness trials in this. And so they have a bit of a smaller number, although it's 11 RCTs here and 863 patients. Just to summarize their findings then, again, significant small to large effects. That's a very rough summary, I'm afraid. I'm sorry about that. for ACT over control conditions, for all the, the main key outcomes, disability, anxiety, and depression, but not for measures of quality of life for some reason. But so overall, a positive summary for these trials. But as you'd imagine, the usual conclusions are also included, which is the quality of some of the studies could probably be improved, and that would be good. All right. So I'll show you a little bit about some of the things that we do in our data. So something that we're finding with this model of psychological flexibility, that the model is supported not in ACT showing significant effects. The model is supported where when you demonstrate improved psychological flexibility, you demonstrate improved outcomes at the same time. So if psychological flexibility is enhanced and outcomes are improved, that supports the model. If ACT doesn't give you good outcomes, it's a technical failure, probably. It's not necessarily a theoretical failure. So that's a distinction we like to make. But something that we've been interested in is, we get our data within our services for the most part, occasionally in a trial done outside of our service. What we've been interested in doing is finding increasingly more precise ways to measure aspects of psychological flexibility, to measure whether they change in treatment, and then to measure whether those changes in psychological flexibility are indeed correlated or associated with improvements in people's performance and well-being, as the model or theory would suggest that they would be. And so here's an example of a study. This was done by my postdoc, Whitney Scott, one of our MSc students, Katie Hahn, and I. So it was just a consecutive cohort, 384 patients from our service at St. Thomas's. The treatment we do there for most patients is a 4-week interdisciplinary, group-based pain management treatment. These are highly disabled, highly chronic, highly comorbid. So these are sort of tertiary care, specialty care patients, and not sort of, I'm tempted to say, not run-of-the-mill general practice or primary care, but you know what I mean. So here's, just to get right to the heart of it, again, what we're interested in is, do changes in psychological flexibility associate with improvements in outcome? This is a correlation matrix. These correlations are correlations between change scores calculated in regression. Here's some of your sort of normal outcome variables: pain intensity, a 0 to 10 rating. You'll recognize the SF-36 physical and social measures. The PHQ, of course, is a measure of depression. Here's some of our process measures: pain acceptance, cognitive fusion, and a measure of decentering, which is something like cognitive fusion. Down here we have something called committed action, which is just the ability to persist with functional goal-based action even if things are difficult, basically. So we got these psychological flexibility facets: acceptance or openness, cognitive fusion or diffusion. These things are a little bit complicated. I apologize for the complexity of these. This is like if you're cognitively fused, you're having a thought and it overwhelms you. You don't even know it's a thought. You just think that's reality. So if your thoughts are dominating you, they're dominating in their influence on your behavior, we call that cognitive fusion. If you could step back from your thoughts and you could see, oh, that's just a thought, that's sort of cognitive diffusion. So this is really a functional aspect of cognition. Whatever the thoughts say, either they overwhelm you and they dictate what you do, or you're back from them and they don't overwhelm you or dictate what you do. It would be like the difference between having the thought, I'm having a heart attack, and being panicked by that, versus having the thought, I'm having a heart attack, and not having any emotional response or influence on your behavior. So it's sort of that's the crux of this fusion and diffusion concept, part of psychological flexibility. So what you see in the correlations then is not too bad. We got some, of course, significant correlations with physical functioning here. These are the key boxes. Some pretty good ones with social, and pretty good with depression. If you look at these in hierarchical regression analyses, you see that change in pain we put in here as a predictor here's our dependent variables, or the variables we're trying to explain with our regressions. Here's our change in pain score. Here's our change in psychological flexibility score. So in these boxes here, you get, this is like a percentage of variance. This is a change R square value, 7, 3, or 6% of the variance. And these improvements is correlated with improvements in pain. You put in the psychological flexibility variables after that, and you get, pretty good proportions of variance accounted for. Changes here overlap with variance in these facets, 15, 24, 27%. And this is post-treatment, and this is follow-up. So that's not bad, sort of for psychology data. What's neat is that, acceptance we've been studying for years, and I think it's pretty well known, and people study it, many people other than just us. And so I think it's pretty well known as a kind of a potentially useful therapeutic process to be able to be open and not struggle with things that bother you and not go into avoidance mode is the essence of acceptance. But it's neat now that we can see some of these other interesting facets are coming in and also accounting for variance. And that's the cognitive fusion or diffusion process and this committed action, this other aspect of psychological flexibility. So this is the stuff that is you would never see coming from my mouth or something like that. This is a bit of neuroscience-y brain imaging type stuff, which I brought in here because I've always been fascinated with this one. So this is a study of I think it fits in with many of the things that we've seen today. Here's a small trial of CBT, is what they called it, in women with fibromyalgia, where what they included in here, and this is a group from various places, including Boston and from the Karolinska in Stockholm. I'll just tell you, it's a small trial. Here's their consort. 43 people randomized either to CBT, is what they called it, or a waiting list. And you see they retained people pretty well. Basically, the study was 12 weeks of treatment or 12 weeks of waiting for treatment, depending on which arm you were in. They did a pressure pain exposure before and after treatment and did a fMRI with everybody. They measured some other outcomes, depression, anxiety, and global impression of change. The CBT condition showed improvements. People did well in that. Their improvements were superior to those in the waiting control condition, so that was good. And there were a few findings on fMRI that showed differences between the two groups. And here's the neat part for me, because I'm saying that these contextual approaches to CBT that are developing and available these days, and it just so happened that the version of CBT that they put into the CBT trial was in fact ACT, and that was done by Ricard Wixell, some of you may know, and his colleagues. So it's basically an ACT study with fMRI data. So you guys will make much more sense of this than I will. All I'll say is that there were fMRI differences, so there were changes in fMRI results for the ACT condition relative to the waiting list condition, and they were generally in prefrontal cortex areas. There was some increased connectivity between prefrontal cortex and the thalamus. Here's some of the pictures for you. Here's the very small graph, I'm afraid. Even in the article, it's almost impossible to read. But this is showing increased connectivity between prefrontal, ventrolateral prefrontal cortex and thalamus. And here's a chart of the data, a table of the data, shows you some of the effects between the two, differences between the two arms. And the author's conclusion there that they found some difference. They called these differences in executive cognitive control processes, which I find interesting. And anyhow, there you have it. Neuroscience meets clinical treatment trials. So I thought that was all right. All right. So I have a sort of a mix of somewhat unusual, possibly, conceptual points or summary points I thought I would wrap up with. So for one thing, from a psychological point of view, as I say here, behavior patterns emerge and persist from these historical influences. A psychological perspective is, to me, a contextual perspective. In the environment, situations, and history coordinate what we do, what we think, what we feel, what we do, how our thoughts and feelings interact with what we do. It's all contextual. Exposure to adversity probably sets up a pattern in behavior that probably has a self-perpetuating quality to it. You perceive threat and you start avoidance patterns. They have knock-on effects during development, no doubt about it. I think some of these effects are sort of probably what we would call early roots of psychological inflexibility. This avoidance patterns, experiential avoidance, perceived threat, run away, and so forth. Very narrow patterns of behavior that are more focused on things to avoid and getting out of difficulty and such like, more so than more positive patterns of engagement, awareness, and connection. So there's a perspective here, I think, that these patterns of behavior are patterns of behavior done by people. They're not done by your mind, and they're not done by your brain. There are treatments that sort of conceptualize these processes that probably, as I say, arise in early life experience and conditioning your whole life. And we know these treatments do these things as well as we can measure them. Our precision isn't great. We're using self-report. We're clinic-based. We're not laboratory scientists. We do the best we can to measure our variables largely by what people say to us. Even so, we think we're getting at this kind of reduced response narrowing functions of experienced events. People run into pain. They can do more than avoid. They can engage. They can incorporate. They can keep working on their goals. We think we can get this increased context sensitivity by reversing avoidance patterns and by undermining verbal cognitive influences that create this insulation between our behavior patterns and what's available in terms of contingencies in the environment around us. And these kind of processes that we've heard, sort of touched on today, processes of meaning and motivation are, for us humans, these are largely verbal cognitive-based processes. And if you want to manipulate them, this is what we use to build patterns of behavior that can run into difficulty and persist in the long run. That's building persistence. This is the one thing we know about verbal processes. They create persistence. If you hold an idea or a rule or an instruction and you follow it, it's probably going to create a very persistent pattern of behavior. So what's also neat about this stuff is this isn't some sort of model that someone made up in the back room doing a lot of therapy and then coming up with a story about it. This stuff is fundamentally based on sort of conventional operant conditioning theory extended to include verbal and cognitive processes, or what's called functional contextualism as a philosophy, or contextual behavioral science as an approach. So part of the story here was about a model of psychological flexibility. It's a model not of pain. It's a model of behavioral performance and well-being. It's connected to, it works well with brain science. It works well with evolutionary theory. It fits. It's a very evolutionary selectionist model of behavior in many ways. ACT is not the same as psychological flexibility. ACT is a vehicle for psychological flexibility. It's our current vehicle. We may need a new vehicle one day, but it's the vehicle right now. It is very process or mechanism focused. We can conceptualize these processes of pathology, and the treatment is designed to undermine them essentially. And it can certainly, I think, include a way to look at and understand early life adversity and all the things that happen there. Thank you very much.